Can you please give the particulars of the case first? First, let us present the case. LED long segment, this is a lesion we have. 46-year-old male, no known chronic disease, atypical chest pain for 7 or 8 months, and the echo findings are normal. And BT angiography was done in LAD coronary artery from the mid segment. Clear calibration and contrasting diminishing exists in LAD. D11 is seen obstructed after the angiography. Well, after the case, we see that LAD total is obstructed and diagonal is after the diagonal, there's obstruction. There's an atypical case, whether it is CTO or recanalization, we were not sure about it. And actually there is channel, there is transition, but the vessel is totally deceased. Therefore, in order to understand it, an intracoronary imaging was required. And before the panel, we wanted to pass the lesion with an IVUS to see the diameters of the vessel. And what are the recommendations of the panel? So let's talk about your approach. There is a little flow, there is a micro channel. What is your wire selection? Here, a hydrophilic wire will be used, pilots 50 or 150. With a sliding technique, we will pass it, and with a rigid wire, we plan to do an IVUS. And let's discuss it with the panelists. Good luck. Same way, we can start with you. How would you start for such a case? The LAD is critical and there is a serious stenosis. We do not know the distal. Maybe the distal is also ill. We require an IVUS to see the whole, because not only the lesion, but there might be problems in the distal. I already saw the view. Previously, in the mid segment, there is a stenosis, it seems. Therefore, as it may be a diffuse disease, the best approach is IVUS. Murat, would you say something? No, like Nihat Hussein started from the later stage. What was your approach instead of saying the CTA? The wire selection is very important here. I am the moderator. Let me not talk, but I give the floor to you. Just looking at the lesion, wire selection is very important here. Well, in the same manner, the wire selection is very important. A pilot's wire can be used. There are micro channels, and next, after passing the lesion, if we have the chance for IVUS, the distal of the lesion may be evaluated, and then for intervention, it may be better. Like, I agree with Nihat about this. Well, would pilots be stiffer and thinner wire may be required? What do you think? Maybe, but here a dual angiography may be done to see how the distal is filled. In CTO, actually, the first thing to do is this. At the moment, there is not a dual operation. There is no retrograde fill. Therefore, we are dependent on IVUS, right? Yes, pilot wire is suitable for me. Nihat also started with that. Of course, everyone has his own method. It will be good, of course, not to use a rigid wire. In fact, in our practice, IVUS do not exist, and in many centers we do not have. In the first place, using a microchannel is important. Maybe a hydrophilic wire we use, most probably due to the lack of flow, there may be a lack of diameter. After ballooning, and nitrate may be administered to evaluate the distal vessel diameter in a more objective way. And I think there is microchannel. Of course, passing it will facilitate our work. And in ostium, I may have not seen it, but there seems to be a lesion from the left part. I see it. But here in the case presentation, instead of Ömer, Zeki can also present the theoretical information. Now, friends passed it with a wire. The channel was good, I guess, but if the proximal cap was forced, what kind of methods would you use? In the previous meetings, we already mentioned about it, Gaia, or some more rigid wires could be used. Of course, seeing the calcification length of the lesion is important. Seeing the angles are important. Of course, we need to plan it later, depending on the lesion. The lesion was difficult, yes, but with the talented surgeons, they went past it very well. Our colleagues are really experienced. They passed it very well. Well done. Any contributions from the audience? Such a CTO case must be discussed in detail to increase the knowledge of ours. I want to add something. In fact, more hydrophilic wires could be used, but here, in my opinion, we are working in this country. If we are thinking of which wire is suitable, it will be good to start with that. So trying one and exchanging it would be a consumption. It's related to our practice, and everyone uses a different wire. Sometimes we try one and then pass to another. And Nihat is very experienced here. Or depending on the material we have, it changes. Here, what's important here is that if we cannot pass the lesion, or if we are to give it to another session, we shouldn't force it. If we cannot pass the channel, we can try, of course. If you make the patient subject to another session, then you increase the difficulty of the operation. I guess we agree with you. Different virus may be used. Why did we use pilot 50? Is soft. The most ideal one here is to pass the lesion with a sulfur wire. It could be done. Tanner didn't use a micro. We used the balloon. Now we will delete the balloon. IVUS is difficult to pass, especially Vulcan IVUS is a thick one. Therefore, we will do the balloon and then we will see the IVUS. We will delete now. We start from the bottom. Let's inflate. I have a question to Nihat. Good luck, Nihat. Here from the distal, before starting ballooning, maybe the actual obstruction parts could be ballooned. If the segment is really long, we wouldn't see something. Therefore, without much aggressive operations, we just use, because we cannot smooth the IVUS. I think the vessel would be good because the proximal is really good. The diameter is 3.5. We are waiting for the IVUS. I think in CT angio, it was done previously. Therefore, we could see the lesion from end to end. Maybe this has a handicap. If we are going to see a good segment, then we're trying not to damage it. We may need a long stent here. We will administer nitrate and take a view. Okay, actually, the vessel is better now. We can do an IVUS to understand what happens. In fact, this case is ideal for a drug balloon. We can discuss it, where to use drug balloon. And the diameter of the diagonal is not certain now. You use the a wire, but whether it will be a provisional or planned to vessel approach, it's not certain. What do you think about the drug balloon in your practice? To use it? Not in my daily practice at the private hospital, but in theory, if the vessel diameter is not good and if we are to avoid to place a stent, we need to use it to prevent restenosis. What are your opinions about this? About drug-coated balloon? In the studies, especially for the vessel diameters below 2.5, is non-inferior compared to stent. So this will be an ideal one if the distal diameter is bad. Especially for such diffuse patients, it can be used. It will decrease the metal load. I do not know the diameter of the vessel, but if there is any possibility for surgery, you give this chance to the patients. The most important here is a small diameter stent, which may cause stenosis. Do you see the IVUS? Yes, we can. There is no lumen in this distal part. And in IVUS, the French area is 2.3. We will pull it back now with a scope. Pull it back now. There is no lumen, you can see. Here about IVUS, I can say that the distance between the points is 10 millimeters. We cannot see the lumen here. You can see the side branches, the veins. This is a vein. Still, there is a lumen, you can see. Again, here there are new lumens. Interestingly enough, let's stop here. There is a lumen now. Can you please comment on this? You can see the penetration. IVUS can be used for the penetration. Now, there is a pull now. Pull it back slowly. Here, the lumen is good. There's a concentric atherosclerosis. Pull it back. You can see the septals. Stop it. In fact, the back segment is ill. There's also a negativity. At the most distals, there's a collapse, not total atherosclerosis. And there is a serious branching. And you can use a larger balloon to dilate it, or drug-coated balloon can be used later.
Can we use nitrate option here? Any other suggestions from the panel? Do you have any other suggestions from the panel? There's a collapse for nitrate. How much time should we give it? 2 or 3 minutes? We did it 5 minutes ago, and we will do it again. So many things have been done to trigger spasm. The CT images are very bad. We cannot see the vessel. Let's delete this part. Can we see the IVUS? So to see it, we have the distal part. We cannot see the lumen. The catheter closes at the lumen. From the mid segment, we can see the veins right now. So it is very pointed. So there is no lumen there. Atherosclerotic plaque is not done. Congenitally, is it a very narrow vein, or it's a spasm? There is a negative remodeling, and spasm is there as well. I think that this vein will be treated in the future with the good radius. You can see the lumen. Our lumen is here. this is the radius. So with the elastic radius is 2.5 mm. We see the fire. We come closer to the diagonal. We can make a measurement. If we make a measurement here, there's a 2.5. We are going to delete here 2.5 with 2.5. We have a branching above. For the reference segment is important. The reference part is here. If we can put it here 2.5 cent. Can I say something, sir? Dr. Arif is my name. Distal luminosity the catheter procedure with a micro catheter can be attracted. Maybe the nitrate has a better distal effect. Proximal LAD radius is 3. So it is 2.2 and 2, and the patient doesn't have a diabetes as far as I know. There's no diabetes. There's no diabetes. Now it is there. The diameter. Now we will take another imaging. The echocardiographic imaging of this patient is quite normal. This is the flow is partially enough for vitality. So for years the patient has a spasmodic problem. This is negative remodeling. Or if there is a clotting, there is no hatching there, and we have to be careful about this. And so we can see that we believe that if we open it, it will be very bad. It is better that the radius, the diameter increases, as we can see. It is better right now. We are thinking of implanting a stent there. We can make ballooning in the down part. Anyone who'd like to say Ali Bey? Did you make the nitrate? We made the nitrate thing. So instead of this, maybe there could be ballooning medicated with instead of medicated blood, maybe a control angio within a month. This when we look at the CPO segments in LAD, we see such results are very bad in segment CTO. After a huge diagonal and septal giving, there is an underperfusion concept. As far as I know, there isn't. In fact, there are. It shows that the tissue is vital as the perfusion pressure is decreased and the vein gets thinner to have this. In lima graft, we see it very commonly. If it is a lima thins itself, however, when you have the nitrated, it is dilated, and this is the vascular structure and vasomotor relation. After CTO segment is taken, the operators generally they're trying to stand from the distal, and this shows that we are in the lumen. The lumen is intact and there is no atherosclerotic formation. It's about the vasomotor structure. Here, actually, as the professors pointed out, after waiting as the perfusion pressure increases, it will go to normal size with your segment. We can stand this around in this segment. When there isn't good perfusion with the ballooning, the messaging could be there. The reason why I'm saying is that when you put the stent there, place the stent there is a thrombosis risk there. So I don't think that medicated ballooning is the right approach. But when we see the atherosclerotic plaque in the distal area, with the medicated balloons could be used, but with the CTO segment should be closed, I believe, because Nihat, if you think that this vein is there is a true and true ballooning, and there is no dissection right now. If we are talking about the medicated balloon, from the first diagonal to the second diagonal, there could be the medicated ballooning could be there. It's an alternative to stent. In the distal segment, it is important that this is the physiology of the vein. If we take it within a month, the vein will be looking better. Thank you very much. Stent is more reasonable to us. Maybe we can recall our objective is the proximal stenting and medicated ballooning for the down part. In the IVUS stent there, the distal wire can be taken back as for the case. So when we have the ballooning, if there is a section, if the medicated ballooning is working, we can use this in the stent. The long-term results will be better. Placing medicated balloon there for the plaque part, the balloon medicated ballooning, and when we look at the proximal diameter, the distal will have a larger lumen. So therefore, I may talk about the nitrate, the perfusion pressure increases, the distal will be more in a more shape. There is no need for stenting. The stenting is a very effective, so you can say it very clearly. It's a very impressive crossing there. We will close proximal and diagonal. What is the stent sizing? Based on the this part, 2.5. 3.5 pot. In the total occlusion opening, one of the things in CTO, when there is no iris there, these sizes can be lower, and of course this affects the situation. And proximal 3.5, distal 2.5, can we select a 3? Reference diameter is important. Potting is there, important for us. What is important in stent size? Of course, in order to prevent shifting in the side branch, it should be selected based on the distal. It is much above. Distal diameter is there, spasm. IVUS measurement is done, and there's a nitrate let's have a nitrate film. So 3.38. What is your comment, the professor of all of us, Ali Bey? What do you think? Microphone, please. I came a bit late. I cannot say anything about the beginning. And it is still, there's no atherosclerotic plaque that is seen. Medicated balloon. Effect of this, it will block the proliferation. If there is a spasm, as a KÜRŞAT pointed out, if it is about the vasomotor changes, I don't think that the medicated balloon will be there. If there is a protection of inside thrombus, if we are thinking of a dilation, it should be made with the simple balloon. I think it would be understood if you insist on doing that. I don't think medicated balloon will be good, but the other parts are going very well. Toilet here. Six. We will make the pot above. We dilated the other part a bit. Six, 8, 10, 12, 14, 16, 18. A bit, let's add a bit more. The opening is very good. There is a flow there. We put a firing for the part below. It is a less than 2 mm. We are making this second pot, 16, 18, 20. Let's have a nitrate so we can have a new iris. Maybe we can see the plaque and we can see how much, what's the percentage of plaque. So let's take the balloon, let's have the nitrate. Nihat Bey. We can have a new iris, so we will see the part there. Let's have a nitrate CTO. Let's have the imaging. In the stent distal, there is a flow slowing down and irregularity, but we don't have problem with the above part. Sizing is good, 3.5. Now let's have a new iris so we can see the opening of the stent, new iris. There are plugs, so we can have the medicated balloon there. Can I say something? When we have the complex economy, we experience a handicap that we do have. And the ballooning after the stenting is better. I think that everybody has the same operator. This is a disappointment for the operator. Like Moderatörler, but there is a flowing. What I'd like to, in acute coronary syndrome, in the patients that apply to the hospital with the syndrome, there are subtotal functional CTO patients. So there is a troponin increase in elevation in this patient, and there's a vulnerable plaque. Actually, the lipid core is large, and there are thrombotic. Once in the first standing, when we default standing with this, we can in the new session or in a few days, and when you take the patient, you see that the number of vessels increase, veins increase, and the treatment is better. With the slow flow of risks are minimized in this regard. In such cases, actually, these are some of the cases that we have CTO, so they have a critical narrowness and there's a plaque. And actually, in this case, I'm not saying about this case, but for CTO for complex coronary, our friends should be careful about this. This is what I recommend. Because when you put the stent, when you make the port, there is a slowdown of the flow. And the patient can go into myocardial infarction as well. Thank you. KÜRŞAT. We agree with what KÜRŞAT will say. This is the IBIS. It's Skopje. We have a space here. There are negative pneumatic areas in the areas where possibly there is a spasm. We don't see a plaque load there. We will enter into stent. Right here, the opening is very good. There is no emptiness. The plaque is compressed. There's underside. I think the opening is very good. You can see the mount of the diagonal. We have the port to 3.5. There is some more position. And the reference diameter, this is very good. We're going to check this cell. Its reference segment, the stent is there. We are in a good position. I think that in the below part there's a spasm. As Alibe pointed out, there is no plaque structure there. I think that we should leave the patient like this. What do you say? From the moderators? Little nitrate once again. We will take out the wires and we will take out the wires and in the IVs because there is no plaques, there is no plaque load, there is no dissection. The latest data is that for the IVs and FFA, so that there is a new application there. If the lumen area is below 3 mm, there is stenting. If it is a 3 or 4, it's below 3 or 4, we need to look at plaque load, whether it is exceeding 70% or not. The plaque load is at 10 to 20%, so we cannot have a medicated balloon or stenting. We will take out the wire, and we will give nitrate. Anyone who'd like to make a contribution? I don't think that this runoff is very good. There is a stenosis risk and there is a thrombosis risk. With the normal ballooning, I think that what happens if there's a normal ballooning? If they're going to make a nitrate, so everyone thinks that there's a spasm. I will take out the wires. Let's have a nitrate and wait. So we can see the left cranial angle. Let's first see from right hand side. From right hand side. In septal and diagonal, so that the tissues are filled with blood and it should be emptied. If the diagonals and septals are blooded and then flushed out, this could be related to lipoperfusion. So cardial and septal veins are very good. I think that it's better. The side branches are filled. I think that will be better in time. Let's have the last pause. We're in a better position, I believe. And with IVUS, we comfort there is no dissection, there is no other branching. The diagonal is there. The last guidelines insistently say that there should be standing. And anyone who has a suggestion, or let's leave it like that. What do you say? Thank you, we say. Side branches are there. The distal, in the distal, it's not a nicer picture, but following we can say that with the standard, so there's an ambulation out and distal flow is there, and with the size, so that you cannot do, there's atherosclerotic plaque, maybe we can think of ballooning. But it's we believe spasm, and I think that leaving it like that, that will be very good. I'd like to make another nice comment. In circumflex at this, can you say the collateral to the apical? It's the reason why we see it about the hypoperfuse. So the collateral flow, it's about physiology and it's about the tissue will repair itself, and it's about the retrograde and the club is there. So you can see this, so it's not a good bad idea. So we can just feel it there. Thank you very much. We are finalizing the case. Thank you. Thank you. So the presentation, case presentation, Zeki Bey has been waiting. I'm available, I'm waiting. It's okay if Zeki Bey starts. We can listen to you, Zeki Bey. You can see it right now. I'll talk about the medicated balloons and using them in the coronary artery disease. In coronary artery, in order to get rid of coronary artery disease, there are both pharmacological and mechanical developments. There are the imaging techniques. The success rate is increasing day after day. Although there are such good positive developments, there are still some cases that the success is not possible. In 1979, there's a balloon, and in 1988, there's experimental stent, and drug electric stents there is in 2003. After balloon angioplasty, there's intimate sex and coroners. In BMS and the drug eluting stents, there's restenosis and thrombosis. And then there's a fourth letter, there's a drug coating balloons, TCB, and there are the bioresorbable vascular scaffold stents. And of course, these are not giving gave the right results. This didn't give the right results. However, drug balloons there are important. The philosophy is that leaving nothing behind. This is the basic philosophy, as we have seen in the case that there's if there wasn't any stenting there, if we had the same result with the stenting, so what could be the result? Or of course, that there's no the absence of stenting would be a better situation. For DCBs, in 2006, the DCBs came into our life in 2006. There is a with instant restenosis, is compared, and it was very successful. What is it? The drug coated balloon. So it is with the transfer of the antiproliferative drugs are transferred to the paclitaxel coated balloons are there. There is why paclitaxel. There is paclitaxel coated balloons are the most used one. These are between 2 and 3.5 mm paclitaxel, and there is a matrix coating there. The dosage formulations, illusion, and also the interactions are important. And in DCBs, there is no effect of glass. Paclitaxel has a high lipophilic characteristic, and with sirolimus and derivatives have been approved, and there are other studies. So why paclitaxel, when you ask? Why paclitaxel? And the stents there are given, and there is because of the lipophilic characteristic, the penetration to the tissue is more. So this is the molecule most, and with technological developments, other molecules are used, and these are most found to be more superior with the test, and for this DCB. So what is the practice?
The inflation is required to be minimum 30 seconds and over to ensure full adhesion, and the under an atmosphere pressure of 8 to 12 atm. And the auxiliary material is important in order to increase penetration to the tissue. And works about the other molecules also go on. And when we look at the balance lengths in the market available, from 2 to 4, there are present. Even 1.5 sizes exist, but I couldn't find. But the commonly used sizes are these. And also in the markets, the available medication are these 12 or 13 drugs, and the companies are already written, and of course the CE mark is the European mark, and FDA approved one is Medtronic, which can be found in the market. Drug-coated balloons, and actually we are all aware of these. Drug-coated stents are already known, we know them. And of course, later the stents the stent remains there, and drug is released from time to time, and this is an advantage, and overdose is prevented through not continuing the medication for some time after the stenting. And a drug-coated balloon is indicated for certain instant stenosis or tiny vessel diseases or bifurcation lesions. And these are already written in the guidelines, when we say small vessel diseases, it is 2.75 and below. And the de novo lesions, the patients with high bleeding risk who cannot use the dump for a long time, and the patients with common distal vessel disease, especially for diabetic patients, these drug-coated balloons are used. As the country, we do not use it much. In our clinic, we only had 20, and we used them. We couldn't follow up patients for a long time. And especially at state hospitals, we do not have the chance to use them. But when I search for this, there are serious information about this, especially in Europe. The drug-coated balloons are used, and there are many studies about it. What about the guidelines? The guideline of ESC in instant stenosis, it is indicated for class 1, as class 1, and after 3 years, the US guidelines were published, and they do not take into consideration the Eastern publications. There is no indication in the US guidelines, but in instant stenosis and scoring, cutting balloon, and muscular catheteresis, the drug-coated balloons are used. And then a consensus report was published in 2020 by the European associations, and for the bifurcation and for large vessels and in acute coronary syndrome, the drug-coated balloon can be used, they say. And this consensus is really important, and the method also is described. The lesion must be prepared with optimal, and predilatation must be done, and if necessary, scoring, cutting, and NC balloon dilatation size can be used. Additional monitoring methods must also be used. In preparing the lesions, after the lesion is prepared, if there is a dissection not restricting the flow and the residual stenosis is less than 30%, and if the FFR is more than 0.80, drug-coated balloon must be used according to the European consensus report. But if there is a suboptimal angiographic result, and if there is a flow-limiting dissection and residual stenosis is more than 30% and FFR is below 0.80, then this drug-coated balloon is not recommended. After a good lesion preparation, as an alternative to DES, DCB can be used, and also in the complex coronary interventions, it can be used as a result. And again, in the same report, in instant stenosis, the drug-coated balloons can be used and as non-inferior. This is already known. And about the de novo diseases, the DES seems to be superior compared to the literature, but it is because of the usage methods. And if the vessel is small, The publication says that the drug-coated balloons are equal to the drug-coated stents. Until 2020, these were the developments. In 2021, again, more than 80 studies were done. And what attracted my attention is that is the following reviews, especially in CTO. Long stent use will increase the residual stenosis ratio, and after PTCA, stenting the necessary areas. And drug-coated balloon usage, drug-coated balloon use will decrease the total stent length in a review, and especially in O101 or O11. So in such bifurcation lesions, when we place provisional stent, the side branch can be used, can be administered drug-coated balloon, which is superior to the normal balloon in this study. Again, for the small vessels, especially under 3 millimeters, drug-coated balloons are said to be safe and efficient as much as stents, which was published in 2022. Especially the bifurcation lesions and unstable adenopectoris studies go on, and you can see the details of those, and long-term studies are also going on. When we look at the mid-term results in new de novo lesions, the results are quite reasonable. Again, in cardiovascular medicine 2022, in a study of giving the 1 year results, means MR, the results are similar. This also again good. All one lesions were taken into consideration, especially the benefits of the drug-coated balloon medicine. Drug-coated balloon treatment is said to be good. For the complex coronary interventions to decrease the stent thrombosis, and for the long bifurcation lesions, it can be used, and in the 2 years makes results are similar to death. As a result, what are the fields of use? Instant restenosis. It can be used, and it can be used in bifurcation lesions. In de novo lesions, it is recommended, especially for the patients who cannot use drug for a long time. It can be used. As a result, we can say that for these patient groups, we can make a plan specific to the patients, and drug-coated balloons are a part of the puzzle. While deciding for PCI, drug-coated balloon must be taken into consideration, especially for complex lesions, for single or double stents. In the target the vessels, there is no residual, which is the best attractive feature, and in the future it will be on our agenda. Thank you. Zeki, thank you very much for this nice and informative talk. Any questions from the hall? From the panelists? What about the underground treatment after the balloon? In the consensus report, the ideal one is said to be 3 to 6 months, but if necessary, it can be reduced to 1 month. Of course, the period is not that short, but for certain patient groups, especially for hematologic patients, even 15 days of non-use is recommended. Zeki, thank you very much. In the use of these balloons, about the preparation of the lesions, can you inform us, please? Do we need to prepare the lesion, and what kind of a strategy should be adopted? We require a good lesion preparation with a semi-compliant balloon, if necessary with an NC balloon. And 1-to-1 preparation is required. Can you see my screen now? We do not see the slides. I want to show it to you again. Drug-coated balloon nearly 4 years ago was procured by our hospital. Around 20 balloons were procured. Here you can see, I think, especially an optimal lesion preparation is required. The lesion must be prepared with a standard semi-compliant balloon, especially with cutting, scoring, or non-compliant balloons, and then drug-coated balloon must be implanted. You can see the preparations in the left segment. A serious preparation is required. One of the most important handicaps of drug-coated balloon is that in the densely calcified regions, the drug penetrates to the tissue less. Therefore, the result is not that effective. Therefore, in such a case, preparing the lesion is important in selecting 1-to-1 size balloon, and in certain calcific segments, the tissue perfusion is increased, which will increase the efficacy. Here, another important point is that in preparing the lesion, if we act too aggressive, then dissection problems may occur. Therefore, the anatomy of the vessel is required. In my daily practice, instead of 1-to-1, I prefer 1-to-05 predilatation. And how should we keep it? The publications are conflicting. Some say 1 minute is enough. While preparing, what's your recommendation? Minimum 30 seconds. And in 30 seconds, up to the level the patient can tolerate the pain. It shouldn't be under 30. It should be over. The longer it is kept, the better it will be. And in my opinion, up to 1 minute, it will be good. Another technically important issue, while loading the balloon to the wire, we shouldn't touch upon the balloon because Actually, we shouldn't touch the stent as neither, but during the passage, opening the Y connector and making it pass without friction is important because it is fragile. It has a fragile loading position. If you distort the balloon structure, there will be problems. Therefore, until a certain area, you must push the lesion. About this, I just wanted to attract your attention. Sometimes we keep in mind, and as you have already mentioned in the drug-coated balloon, in some patients we are anxious about wrist stenosis, especially in LADCT patients. Long segment stents are placed, and after wrist stenosis, re-operations are required, and infarctus occurs. And the patients who are referred for bypass in the future, especially after the first and second diagonal separation, if a stent is to be used, we must think that there is no segment left for anastomosis. We should keep it in mind, and effective solution must be created. Thank you very much. Thank you very much, Zeki. It was a nice presentation. In such cases, you inflate the balloon for a long time to avoid any stent use. Now I understand that due to thrombosis, the drug-coated balloons will be more used. I had a patient, TX opened well, and then a stent was placed. And after the stent placement, and we talked about the tiny vessels. I had a case, 33 years old patient, coming for hair implantation, and there he had an eye, and we did angiography. RCA was very big, and we talked whether to use a stent or not. And if there was a drug-coated balloon, it would be better. With a big balloon, we could do the operation easier. Now we use the stent easily. When I first came to Kayseri, one of my patients said that I had an angiography for 38 times, I had 12 stents, and I had 2 bypasses. And I saw the patient. I told him never to undergo angiography again. And in such cases, actually, there's not much thing to do. Therefore, drug-coated stent will be very useful. And the tiny vessels, actually, we, of course, do not want to increase the metal load much. Drug-coated balloons would give that chance to us, especially in provisionals in side branches. A secondary stent will not be required. So such advantages of the drug-coated balloon is good. We have 10 minutes left for the case presentation. Are you ready? Can you see my screen now? No?